individual in order to make insurance markets work, to prevent managerial economics concept force, adverse selection from happening, prevent people from waiting until they're sick to buy insurance. All the other parts of the law that kick in, as I'm going to go into a little bit of detail here, and with maybe one or two other things like having a certain time when you have to enroll in insurance and an increase in prices if you don't enroll, say, in November, like most of us do with employers. I don't think you actually would have needed the individual mandate to make the insurance markets work. So I think it was a bit of a red herring, to be honest with you. We've got the individual requirement. There's also very important, there's a requirement to offer minimum essential coverage on employers with more than 50 full employees, and penalties between $2,000 and $3,000, depending upon circumstances, again, for not offering your employees affordable coverage or for offering no coverage at all. That in a little bit more detail as we go on. There's a small employer tax credit, so there's subsidies to employers to offer insurance. The next bullet point, there's a huge expansion in the Medicaid program. I'll go into a little bit more detail on that. Medicaid, of course, is a joint federal-state program to offer insurance to low-income people. It's been to the states to determine who they offer that program to, and the Fed mandating that it be offered to a lot more people, up to up to like 133% of the federal poverty level. We'll talk about that. Bullet point up in the upper right-hand corner, subsidies to individuals 400% of the federal poverty level. I'll give you some more detail on that. This is a really important part of the Affordable Care Act. So you're required to buy insurance, but if you buy insurance, there's going to be a subsidy for you, and it's a pretty hefty subsidy. Exchanges are going to be created, and these exchanges will be where people are going to be buying insurance, at least some classes of insurance. And there's standardized policies offered on those exchanges with different tiers: bronze, silver, gold, platinum. Different tiers, different qualities of insurance. There's a bunch of rules on general health insurance rules. You guarantee issue, you cannot turn people down. There's no pre-existing clauses. There's no lifetime limits. Limits on how much you can vary the premiums for health insurance and on what basis. You can only vary the premiums on the basis of age, family status, state living, and whether you smoke or not. Tax, lots of taxes in this act, of course. There's a large increase in Medicare taxes. For those who earn more than $200,000, your taxes are going up starting 2013. That's an increase in the Medicare tax from 2.9% to 3.8% on all income above $200,000. There's so that 3.8% is going to apply to honored income, and in fact, the 2.9% is going to apply to honored income for the first time. So capital gains and dividends are going to be taxed on Medicare tax rate. That's big. The tax on so-called Cadillac plans, Cadillac health plans, are really expensive health plans that a lot of employers offer. There's taxes on the pharmaceutical industry and the medical device industry. There's a tax on the insurance industry by itself, and a tax on tanning salons. And somebody said that was put in, I think, on behalf of the Speaker of the House. A lot more changes here. Medicare dollar changes, so some cuts to Medicare. The main one that I'd focus on here is this thing, cut in disproportionate share hospital payments. This is a $155 billion cut over 10 years. Hospitals, the assumption that hospitals are going to be treating fewer uninsured patients. They're going to get much less money than they've been getting from the federal government to essentially pay for those uninsured payments. That's a big ticket, and it's got ramifications, as we'll talk about going on. There's several measures, actually a lot of measures that try to get at actually improving the quality of care and the performance of the health system. But let's be clear, this act is mostly about expanding insurance and providing for that insurance to be paid for. It's not an act that really has a lot to improve the quality of the health system per se. It provides for ACOs, accountable care organizations, which is something that was really invented at Dartmouth here at the Dartmouth Institute. The Innovation Center, there's money for comparative effectiveness research, and there's a variety of pilot programs, including a national strategy on prevention and wellness. But everybody admits that this this law is really not about improved care per se. It's about expanding insurance. So let me just say, if you think about our overall healthcare system, in the end, we're going to have four main ways for people to get health insurance in this country. We're going to have Medicare, which is for the elderly and disabled. We're going to have Medicaid, which is for the low income. We're going to have individuals and small employees buy insurance on the exchanges, and then continue to have employer-sponsored insurance, which are employers. Most are probably covered under our employer. That will still be in place as well, and I'll cover that in a bit, because there's a lot of questions on what's going to happen about that. But types of insurance in this country after this, and that's a bit of an issue that we have such a sort of hodgepodge of things. There's a slide that I just want to point out the subsidies to lower income people to buy health insurance are substantial. The box that I've got outlined in green, the row I've got outlined in green there, this is for up to 400% of the federal poverty level. You will still be able to get a tax credit for health insurance. The way that credit is going to work is it's going to put a limit on what percentage of your income they will allow you to spend for your health insurance premium. You can see for a family of four, that would be about $8,000, the maximum premium that family would be able to spend on its health insurance. And my estimate would be that lowest cost insurance is probably going to be around $12,000. So maybe a $3,000 to $4,000 subsidy that would bring to a family of four at 400% of the federal poverty level. 4% of the federal poverty level, family of four this year would be about $92,000. So for a family of four, up to $92,000, we're getting a substantial subsidy, I would say. And beneath that, the subsidies are even greater. This is a big part of the law, and I think one of the most important ones. So let me just skip into quickly a little bit of the Supreme Court decision, because that was the law, right? That was what was passed back in spring 2010, and that a number of entities, states, individuals, and small business association suing the federal government, and that's the case, of course, that got to the Supreme Court. This is the Supreme Court's decision. This is 194 pages or something. Another great thing to read if you're sitting around this summer with nothing to do. Lots of interesting stuff in there. This quote is from the majority opinion, which was written by Chief Justice Roberts, and I think it's a pretty good summary. So the title of the slide I've given, a saving construction. So what Roberts did, what the majority did, is they said, look, first of all, the individual mandate, that requirement to have insurance, cannot be upheld as exercise of Congress's power under the Commerce Clause. That's what everybody was focused on. It's so interesting. And then in the end, they said, but you know what we're going to do is we're going to reread that law as liberally as we can. And that's the meaning of the saving construction. We're going to construct this in the most liberal way we can, and if we can interpret in a way that's constitutional, that's actually our duty. So you see the second thing underlined there. In this case, however, it's reasonable to construe what Congress has done as increasing taxes on who have a certain amount of income but choose to go without health insurance. So it's not a mandate to have health insurance, even though the word says you shall. It's a mandate. They're just saying this is just a tax if you don't have it. So that's they got around. That's how the Supreme Court got around it and found that it was constitutional. It's a pretty big deal, actually. And if you read the dissent by Scalia and the other three, that's very interesting too. I mean, there's one quote from dissent: "We have never classified, we being the court, we have never classified as a tax an action imposed for violation of the law, and so too, we never have classified as a tax an action described in the legislation as a penalty." So if you describe something as a penalty, it looks like a penalty, it says you shall have something, it looks to them it's not a tax, but the majority said it is a tax. Now very interesting is the interpretation of the Supreme Court take away any illegality and interesting question, does it also take away any unethicality or immorality of not having insurance? If you read it, it's real clear. It is not against the law to go without insurance as pay your tax. It's against the law to go without insurance to pay your tax. But you do not have to have insurance. You just have to pay the tax. This sleeper, again, it's very interesting. People thought that it was going to get struck down, and that this next one is about the Medicaid expansion. Not many people thought that the Supreme Court was going to strike down the Medicaid expansion. The Medicaid expansion, again, in essence, is the federal government providing a lot of money to the states with the requirement that they expand Medicaid insurance for a lot of people in all the states. And the promise from the federal government is that we are going to pay 100% of that expansion for the few years and 90% after that. The Supreme Court struck that part down because they said the states are given no real choice in whether to accept that or not. And the problem was that the federal government said, if you don't accept this expansion of Medicaid, all the money that we're giving you already for the Medicaid program, we're going to take away. And then but if you don't take that, we're going to take everything else away. That borders, or actually is, against the Supreme Court. This is a real interesting aspect of the decision. The mandate was upheld, was struck down. A quick fix to the Medicaid thing, which is states can't opt out of the Medicaid expansion, and the government cannot take away their existing funding of the Medicaid program. Expansion has to stand by itself. And again, I'm going to come back to that because some states are saying that they will opt out of the Medicaid expansion now. The Supreme Court allows them to do that, and that will have some significant implications. So, what do I think? Well, this is a tough one. First of all, I will lay some I'm on the record about 2 weeks prior to the decision of predicting that I thought the Supreme Court would uphold this decision. I'm wrong on the rationale for that, but what the heck, I'll take the correctness of the prediction and stand with that. So, perhaps surprisingly to some of you, if I forced me to say, Bob, will you take the bill as it is or nothing, I would bill. I think on balance, it's just a foundation on which we can build, and also some serious problems that were existing in the health insurance market that were really a blight on this country. There's lots of parts of the bill that I don't like. You see, I've got a longer list on the minus side and on the plus side. But similarly, should we repeal it? I would not say let's repeal it unless that place part of repeal and replace is a real meat behind it that's going to solve the problems that we've got. On the plus side, what do I like about this? Expansion of insurance coverage to the needy. You can be libertarian, you can be very conservative, but you see the extent to which low-income people in this country are not given access to health care. Come on, that's a problem. So reasonable people, I think, want to fix that. Now, we sorely needed fixes to health insurance markets. Getting turned down for pre-existing conditions clauses, that's just something that you really don't want to see. And then I think on the plus side is it is a platform for some experimentation, which is what we need. On the minus side, there's a whole bunch of minuses. Hodgepodge of taxes. It doesn't move away from employer-sponsored insurance as I think we should. It does break down state barriers. We're still all going to be buying insurance with the state we live in. There's too much government control, and not state government control, but federal government control over benefits design. How much you can vary the premiums based upon whether you smoke or not and age. What has to be included in minimum essential coverage. That's going to be a big issue. When the federal government starts specifying these kinds of things have to be covered by insurance, and not even thinking about birth control or anything, just in terms of what's preventative care. That's going to be a nightmare. This bill is going to exacerbate market power on the supplier side. I'll talk a bit more about that, and I think some constitutional issues still linger. But overall, I mean, this is my picture of it, and that there's supposed to be a couple of things showing up here. The heavier side of that scale is equity, and the side of the scale, the one that's up, is efficiency. This bill is weighted towards equity and on-fairness issues and solving the problems. It doesn't do much to solve efficiency problems. For so long, we have not been able to have a conversation about solving the efficiencies of the healthcare system, because every time you try to have a discussion with somebody, the big elephant in the room of unfairness and the uninsured and people who got turned down for insurance or they had lifetime limits or something, those issues always came up. Is now off the table. Now we can start focusing on solve some of the problems. I like slides. Train wreck. I'm not saying this is not going to be a train wreck. There's going to be some serious issues with this bill, and there's going to be some serious changes that are going to have to be done as we start discovering some of the unintended consequences. The title of this slide, we had to break it before we could fix it. My more liberal colleagues have said that, and they're admitting now that it's going to increase costs dramatically. I'll go into some of the reasons why that's going to happen. It's going to increase costs, but they're saying that's necessary because essentially we had to break it before we could fix it. The escalation of the cost is what focused people's attention on fixing this problem. I think overall, if you force say 0-1, take it or leave it, I can take it. There's some people who disagree with me on that, but the Republicans had their chance for many years when they had power the insurance problems, and they did really nothing about it. And I see that they've got a plan right now. So if any election scenario coming this fall, I don't necessarily see the Republicans coming up with something that is going to get us over some of the core problems that we've got in this country that really relate to fairness and equity. But we can't go on to solving the real problems of the healthcare system unless we talk about that. All right, that's kind of background. That's the law. That's the decision. Then too, I've got 4 kind of issues that I think are important to think about in terms of this law. And I'm going to try to go through these quickly. And I'm not covering everything here, but things that I think about that are going to happen, both intended and unintended. So the front, a little man X here. This is supply and demand for health care services, generally speaking. We're with this law, the estimate is about 30 million newly insured people in this country, people who will have health insurance who previously didn't. We know from many studies that people with health insurance consume more health care than others. That increase in demand for health care services, that anchor shifts out. Tendency is price is going to go up and quantity is going to expand. No question. I mean, that's the essential cost pressure that we're going to face. Now, there are some offsetting things. If people are previously uninsured, go to their primary care physician and get preventive care, well, they might not be so sick 10 years down the road. So there are some countervailing effects here, but overall, this has got to be an increase in demand, which is going to show up in a number of ways. This is a slide showing an experience from Massachusetts. Massachusetts in 2006, as Romney's being forced to remember, in 2006, Massachusetts passed its own health care law, Romney Care, and we've got some experience. Romney Care is very, very similar in its fundamental aspects to Obamacare. This is just showing that between 2000 and 2009, if you look at the change in Massachusetts spending on physician and professional services, a good portion of that increase in spending was due to higher prices of those services. That's exactly what I would expect, an increase in demand because more people have insurance, with a variety of restrictions on supply in the healthcare market. And so was it Fabio sent a motion just this morning on the restrictions on the number of physicians who can be trained in this country? Well, that is one restriction we've got in this country. A lot of medical schools and residency slots. So there are restrictions in supply, and I'm going to come back to and draw this as well. A lot of market power on the basis of some of the healthcare suppliers, the hospitals, so they're reaching supply on a monopoly basis. You're going to see a lot of price pressure. That's prediction. This one, and I'll go by this quickly. All these slides are going to be available, but this is a picture from Massachusetts. This is the growth, and you see it between 2006 and 2010, after Obamacare was passed. This is the growth in healthcare employment in Massachusetts. And you see that after 2006, it looks like Massachusetts took off at a faster rate than the rest of the United States. So yeah, we're going to see some increases in price. We will see more real resources, employment, development, healthcare in this country as well. And overall, we're going to go from 17% of GDP up to 20% and beyond. Some of it makes sense, and some of it's not going to make sense. The interesting thing about this study, if you look closer into it, that was not physicians, nurses, the increase in employment. It was administrative people. And what I say is, oh, that's kind of interesting. So as you manage care, take managers, of course. Issue number 2. This is a big one. Okay, this is going on right now as we speak. This is this issue that states can opt out of this Medicaid expansion. Think of now. This slide showing. Let's focus in on. Here's Texas. Texas came out there yesterday. Texas Governor Perry came out saying he was going to refuse the Medicaid expansion. He's going to accept the federal money from it and leave the state as it is. Now, it's going to be up to the Texas legislature, but with Perry against it, if he's really against it, it might be likely that they turn it down. The slide here shows for Texas, over 2014 to 19, 5 or 6 years, whatever that is, Texas would get $52.5 billion from the federal government for Medicaid expansion. The estimate of Texas's contribution to that Medicaid expansion is $2.6 billion. To avoid spending $2.6 billion, Texas is going to forego $52.5 billion. That's the essential trade-off that they're facing. I see they'll make a case, if I'm the Texas legislature, $2.6 billion, and with the uncertainty of what the feds are actually going to give you over the years, once you expand that program, you are not going to go away from it. You can see why a state may consider not expanding this program. And there's quite a few states that are coming out saying they're not going to accept that Medicaid money. So that part of the Supreme Court decision that gave states the opportunity to opt out is actually really important. Here's just one article from July 2nd. Backlash begins. States start opting out of the Medicaid expansion. That's one. Actually, there's a more interesting one here. This was from this Sunday. Georgia looking at the same thing. Now, this is interesting because this points out one of the conundrums of this Medicaid expansion. Suppose that Georgia Medicaid expansion. It's a lot more people who remain uninsured. They're still going to go to hospitals. But the hospitals are getting $155 billion less in money under Obamacare, under the anticipation that they wouldn't have had so many uninsured patients. So if you turn down the Medicaid money, you're still going to have those uninsured patients, and the hospitals are going to be still covering them, and they'll be getting this money from the federal government. So it's going to put a lot of pressure on hospitals. I don't understand why the decision. I think some of the the for-profit hospital chains went up and went into value. Maybe that's because the for-profit ones are different from the not-for-profit ones, but they're not different in terms of their charitable care. But this is a big issue. What I pointed out in red here, this is This quote from the CEO of Wellstar Health System in Atlanta: "Get as big as you can get and as strong as you can get." That's what passes for strategy right now in the hospital sector. And what we're starting to see are a lot of acquisitions. There's a big one going on in New York City right now, in Manhattan. So this Medicaid thing is a big deal. Number 3, employer-sponsored insurance. Again, most of us in this country get our health insurance through our employer. 55% of the U.S. population get insurance through their employer. 15% gets it through Medicare. Again, those are the elderly and disabled. And 16% get it through Medicaid. And the rest are uninsured. It's a big question to a lot of people. What employer-sponsored insurance tends to disappear under Obamacare? And the reasoning of this is incredibly naive. It goes along the lines of, the penalty for not having insurance is only $2,000. But it might cost the employer $10,000. So obviously it's cheaper to pay than insurance. That's just so incomplete it doesn't even pass the smell test. You can't just drop a benefit that your employees have had. Take an employer who's been offering insurance. You can drop a benefit and that there's consequences. You're either going to have to raise wages, raise salaries to those employees, or you're going to lose some of them, either current workers, or you'll be a much less attractive place for people to work. The right analysis for doing this is very, very complicated in thinking about what will an employer do. The big reason employers might drop insurance, because if you have employer-sponsored insurance, many of your employees can go out onto the exchange and now get a subsidy for buying insurance. So the employer will fine wages to employees. They could do that, and can go out and buy subsidized on the exchange. And overall, everybody except taxpayers could be off. That's the actual analysis that has to be done. There will be a reasonable number of employers who find it in their interest to drop that. The estimates of this are all over the place, and you really don't know because nobody knows what some of the prices of insurance are going to be yet. In Massachusetts, just to quickly show you again, Massachusetts had a similar employer mandate. Massachusetts is the red line in this. After 2006, you actually saw employer-sponsored insurance in Massachusetts jump up relative to the rest of the country. It then came down as we went into the recession, as employer-sponsored insurance always does. But in Massachusetts, it actually looks like Obamacare raised the extent of employer-sponsored insurance. My guess is that Obamacare, we are going to lose some employer-sponsored insurance, but it's not going to be very much. And in fact, it's not going to be nearly enough. And I'm using this slide to give my opinion a little bit. I don't think we should have employer-sponsored insurance. If you ask me, I'd much rather get my health insurance not through Dartmouth College, but give me a contribution like they did for my retirement. And we go out onto the open market with these exchanges out there. There's actually going to be products available, and I'll buy the best kind of insurance that I can have. The only reason we don't have this, maybe not the only reason, but a main reason, is because tax advantaged for employers to offer health insurance to their employees. I think we get away from that entirely, and that's one of the things I don't like about the Affordable Care Act, is that it doesn't enough to get us away from employer-sponsored insurance. Buy insurance on the open market. Plans would be much better than what Dartmouth College Benefits Office is able to put together for us. And why should employers be worth health care of their employees? I mean, it's not their comparative advantage. Let the specialists deal with that. It would be better. Number 4, isn't the employer mandate a tax on employment, on employees? So we have to be a little bit careful. It's putting a mandate on employers to provide insurance, isn't that essentially going to decrease in the demand for labor? And I'm going to go through this pretty quickly, but I'll do a few demand and supply charts here for you this morning. Yeah, there's going to be a decrease in the demand for labor. If I have to provide something else, employees, I'm mandated to do that, I'm willing to pay less to hire workers. However, if I'm offering a benefit to my workers, that's something that they value. So at the same time that the demand is dropping down, the supply is shifting outwards. And in a perfect world, as a first approximation, all that should happen with an employer mandate is the wage should fall by the value of the insurance. So part of your payment is going to be in cash, and part of your payment is going to be in the form of insurance. And the quantity will remain unchanged. That's, of course, in a perfect world. There's a lot of caveats. I'm not going to spend a lot of time on these. A couple of the ones that I would focus on, though, maybe that third bullet point, wages tend to be inflexible downwards. For instance, we have a minimum wage. So people at the minimum wage, if all of a sudden I'm mandated to provide insurance, I strike this bargain essentially with my employees where I say, oh, instead of paying you $6 an hour, I'm now going to pay you $4 an hour, but you also have insurance. I have to pay you $6 an hour and provide you insurance. That's the problem. Overall, I have a hard time not seeing this as a net tax on employment, and kind of at a point in time when we're in a deep recession with 8% unemployment lingering, I see this as a problem. As part of the train wreck. Four issues I've covered a little bit, right? Overall increase in demand and supply. What happened to employer-sponsored insurance? This a tax on employment. Oh, Medicaid issue. Real opportunities. Just to throw some things out here. Mergers, both within the hospital and supplier market and in the insurance plan market. There's talks going on in Manhattan between NYU Langone Medical Center, Continuum System, and now Mount Sinai. Who's going to merge in that market? Not long ago, Tufts Health Plan in Boston bought Work Health. And yesterday, WellPoint, one of the largest insurers in the country, I think the second largest, acquired a group in like a $5 billion acquisition, two insurers. So a lot of merger activity, lots of opportunities for health plan creativity, for exchange markets, and for employer-sponsored insurance, particularly in design and networks, I think. Bring in with, explain why the mandate is red herring. Lots of creativity for exchanges and employer-sponsored insurance. I've just got a couple more slides here, and then I'll take some questions. Let's focus on healthcare delivery. So let's start thinking about the actual way that we deliver care in this country. This slide that I used in the introduction to the Masters of Healthcare Delivery Science program, and there are some of the issues that students in that program who are physicians and administrators in health insurance companies, in hospitals and clinics, these are the issues that they're actually dealing with. This is where we start talking about the real value of healthcare delivery. And some things I'll just point out to you. Getting incentives right. So you have incentives for consumers to fund healthcare wisely, and incentives for providers to get away from the fee-for-service system and move to some other way that gives people better incentives to provide the right kind of care, the efficient kind of care. It's another slide from the Masters of Healthcare Delivery Science program. The path, we're even going to get to the peak, but the path to improving this healthcare system is going to be all over the place. Tremendous change going on in the world, huge challenges. It is an incredibly important cause, and now it's happening all at once. It's a great industry to be in, and I would think for Tuck graduates, look, we are disturbing almost 20% of this country's GDP, really shaking it up. If you find some opportunities in that situation, you come back and come back and do some more coursework or something, because I think there's real lot here. All right, so let me take a couple questions. Paul, my colleague, Paul got in. Would you explain a bit more why you think the mandate is airing? Well, what it is, I don't think it was necessary. I do not believe that that mandate, given the subsidies that we've got, which are urging people to get into the exchanges, expansion in Medicaid, and even something like the fact you now have to keep your children age 26 on parents' plans. Things by themselves were going to expand the insurance market so dramatically that it would have taken a lot of the adverse selection problems out. So I think there was way too much focus on the individual mandate rather than on some of the other things that would have paid off analysis in this bill, things that we could have about fixing. I don't think you need it. If you'd done something like, okay, if you don't buy insurance in November open enrollment period, is going to go through the year. That happens for Medicare Part D program, for the drug coverage program, and it seems to work perfectly fine. What else do we got? What does this mean for the career path of our doctors and highly trained specialists? Is this positive and negative inducement? Plus minuses, Mike. On one hand, it's an increase in demand for medical care, right? And there are limits on the number of doctors that can be provided. So on one hand, it increases the demand for those services, and that should make you more valuable. You're going to have to find innovative ways to capture some of that revenue, because I think there's going to be tremendous pressure from private insurers and Medicare and Medicaid to try to tamp down any price increases. Massachusetts is suffering from these price increases, and words along the lines of price controls you start hearing about. So you have to find innovative ways to exploit this increase in demand for your services. Sorry about that word, exploit. That sounds a little harsh. But I were thinking of going into the doctor's field. I'm not sure. It's pluses and minuses. Probably somebody who's unhappy with my acceptance of Obamacare. What did I say? Some economists are saying that the minimum medical loss ratio is unattainable by many, if not most, insurers. The minimum medical loss ratio, what that refers to is that if you look at an insurance company, they have to pay out a certain percentage of their premiums. You can't have administrative costs and profits be too high. I don't know enough, Brent, about where they're setting that, but that's something that indeed have to be tweaked. And I think it's those kinds of, Brent is true, he's not happy with me with my acceptance of Obamacare. But come on, Brent, this is a big problem of fairness. The medical loss ratio, that's probably something that's going to be tweaked, but it's probably one of these things that if you're a health insurance plan or a hospital, a lot of what you have to be worrying right now is what segments of the market are going to be profitable and there's going to be losses. What regulations are going to change, and I think that creates a defensive posturing of, let's just get bigger, let's make sure that our portfolio of services is really well diversified, so that if we're hit here, maybe we'll make it up over here. But if focused only on this part of the market, then we're going to be in trouble. Yeah. Any other questions? What else have we got?
From Josh Glick that came in on the chat.
Glick, the law doesn't seem to address the root cause of cost. True. The law was not focused on solving the cost problem. In fact, it's going to exacerbate it because it's an increase in demand. Along incentives cost. It's a long question, Josh, but there is this business about ACOs, and I should say something about it. An ACO is an accountable care organization. The idea that came from Elliot Fisher at the Dartmouth Institute, and the care organization in principle, I think, is a wonderful idea. A lot of the problems in the healthcare system come about because incentives are not aligned across different parts of the system. I mean, that even happens within a hospital. So one of the projects in the master's program is try to avert patients from using the emergency room all the time. Well, if you keep patients away from the emergency room and you direct them to a primary care physician, say, the difference in compensation that the hospital gets from the primary care physician versus what they lose in charges for the emergency room is negative, right? You're not going to get paid as much for the primary care. But if you look at the system as a whole, there may be a tremendous cost savings from the patients use the primary care physician instead of the medical room. That kind of bringing in of the economic costs and benefits in one entity, to me, is a great part of what's behind this accountable care organization idea. There's pilot programs at this point, and that's what the Affordable Care Act is making possible and stimulating. I don't think ACOs are going to take over the whole market. It's not the silver bullet. It's a good set of concepts, but it's not. Like I said, there's no silver bullet. Ralph Karate, our 2.1% device tax. Okay, so there's a device tax on medical devices. That's 2.1%. A 3.8% Medicare tax in cover, or should we expect further increases? I would say, there's a couple of things in life which are certain death and taxes. I think that this is going to cost more than people expect. That would be my anticipation. So, it depends upon what happens with that Medicaid expansion. If states don't accept that money, then save some there actually. But I expect this is going to be a more expensive bill than anybody thinks. Homer, would you expect insurers to focus more on preventive care now? I think everybody's focusing more on preventive care. The population health viewpoint, I hear that from my healthcare colleagues all the time. Most of our healthcare problems, Paul Gardent always points this out when he teaches a class, our problems are due to our lifestyle and our behavior and our environment. What you can fix going to see the doctor is very, very small. The amount you can fix from being differently, from being more healthy, is huge in proportion to that. Now, how do you give incentives for people to do that, both financially and otherwise? That's a trick. I was glad to see that in this law, expanded discounts that can be given by employers, say, for employees who enroll in wellness programs. There's a pretty big carrot that insurance plans can use to lower premiums to people who enter into wellness programs. Initially, it was a very small potentially that they were allowing for this. But on the push of economists, I think, they ended that. It's great. Yeah, just make Mayor Bloomberg the federal fatness czar. I don't know about taxing sugar, but giving some reductions for people who age in healthy behavior, I think that seems right. Let's see, Laura Fitzgibbons, is there any restriction on providing care to those who choose not to buy health insurance? I'm not sure exactly what you're after, Laura, there, but hospitals still have to provide care regardless of insurance status. Hope is simply that there will be fewer people showing up without insurance. So that's what you mean. There's restrictions on providing care. So if I don't have insurance, I go show up at the hospital and they still have to treat me. But even wiser would be, I don't have insurance. I'm at the hospital, quickly sign on to United Healthcare or WellPoint. They can't turn me down. They can't test for pre-existing conditions. Sign health insurance, so I've got it when I get to the hospital. I jokingly said the other day that the insurers are going to have to do a certain amount of inefficiency to their systems. It's going to take you at least a week or a couple weeks before you're covered to prevent some of that adverse selection. But those are some natural ways that you can actually use to prevent that people from getting into the insurance market just sick and then opting back out. You see some of that in Massachusetts actually. Chris Homer, are you seeing a correlation between the extent of universal care and healthcare costs as percent of GDP? I don't think that's really true, Chris. I mean, if you look in the international comparisons, I really don't like doing those because they're so very different. But, the U.S. is truly an outlier in terms of the percentage of GDP that we spend on health care. And the rest of the countries are much more in a narrower kind of pack. And the main determinant, if you leave the use, I think the main determinant is wealth of the country. So per capita health expenditures rate very highly with wealth. And that's why I often say, look, we're going to go to 20 to 25%, maybe to 30% GDP spent on health. That makes sense. As we get healthier, as we get as we get older, and as we get wealthier, what are we going to spend our money on? We're going to spend healthcare. What's more important than staying healthy and staying alive? It's not necessarily bad to spend 30% of your GDP on healthcare. Spend it wisely, right?
I want to hear about what is the timeline for the implementation of Obamacare?
The timeline for implementation of Obamacare is that it varies for all the different aspects. There's things that have already kicked in, so keeping kids till they're 26 on your health care, which I think one of Romney's kids or something benefited from that. Hey, my kids have benefited from that. What the heck? That kicked in. Other things started kicking in 2013, and then a lot of things kick in 2014, and it's kind of a scaling up. Like the taxes, if you don't have minimum essential coverage, the tax starts at $95 in 2014, and then goes to $695 in 2016. So they're phasing in a lot of these things. Some of the taxes, like the medical device tax in the insurance industry, I actually don't know. I haven't looked carefully enough to figure out how those taxes are actually applied. When the bill, all I saw was that the insurance industry, the law says we want X billion dollars from the insurance industry. And I'm not sure what taxes is it going to be on premiums written or what? That's actually the dollar amount. We want $10 billion from the insurance industry in 2015. Somehow. A lot of things that have to be worked out there. Carl Lewis, will we need a second round of legislation aimed at cost control once everyone gets insured? What happened, that slide I showed was the train being wrecked and then being hoisted up, right? So it's a simultaneous slow motion train wreck with a lot of fixes along the way. That's the most likely thing, unless that we can win big in the fall and actually do manage to repeal this in its entirety. I just don't see that coming. I see a much more incremental approach, Corinne, and things change away. And a lot of the improvements to value of healthcare delivery, to the quality of care, and to paying the cost are going to come on individual market levels. I'm really interested in it, are what some of the health insurers are doing, for instance, in teaching hospitals. So in Massachusetts, Harvard Pilgrim, I think it was, which is one of the big health plans, stopped Partners Health, which is the big monopoly in Massachusetts of hospitals. They dropped them out of their plan. So private insurers are starting to try to do things to put pressure on suppliers to keep prices down. That's great. You don't necessarily need legislation to make that happen. You need some creativity on the part of the health insurers, which, to be honest, I think has been lacking. And you need a lot of creativity to the extent that we still have employer-sponsored insurance. We have the employers' benefits offices start getting creative with their health plans to try to their employees better incentives to care health and use health system wisely, and better incentives on how the employers, pay the suppliers. You don't have legislation for all that. You need managers. You need some ways to get into this market and start creating better plans and some better incentives. I think the prices of prescription drugs and medical devices will increase faster than they have historically due to Obamacare. paribus, other things constant, Obamacare increases the demand for all kinds of health care. Yes, so there's an increase in demand for drugs and devices, and there's a tax on it as well, and taxes tend to be reflected in prices in some way also. So I think price will go up, but at the same time, you've got taxes, and you're going to have a lot of government focus on any in this market who's seen as being greedy. You see in Massachusetts, you get a lot of conversation about boards who are going to be looking carefully at price increases. That's like medical loss ratio. If the camel's nose gets in the tent of, I get to all your price increases, well, at the level we're at right now, the next step is going to be not only can I audit your price increase and judgment as to whether it's appropriate or not, but maybe I'm going to get some kind of stick or power to limit your price increases. So there's going to be a lot of attempts to get into people's pricing power. That actually will depend upon how the politics fall out. So anyway, a lot of things here today. There's a ton of issues going on here. If I were you, I think I'd watch this Medicaid development very, very carefully. If I'm you and you're in any markets, there's going to be a lot of mergers and alliances on both the supplier side and on the insurance side going on. There's tremendous consulting opportunities from the hospital side to individual physicians and networks of physicians. You guys are facing a lot of pressures all the way up to employers and plans. A lot of consulting opportunities. There's going to be a lot of money made in this market. Hopefully, that from an economic standpoint, money being made is being guided as an invisible hand, and behind the money being made is actually improvements in care. Generally, I think that's going to work, right? Where there's great opportunities to make money, hoping that those are the areas where there's going to be great inefficiencies, and the process of trying to make money is going to close some of those inefficiencies. So let's hope that competition will work a little bit better in this market, as in some instances in the past. Thanks much. Hope you guys enjoyed this. We're experimenting with this technology. Gene is working hard, and we had a video last time. We didn't have video. I actually like seeing myself here. I think we're going to try to develop that capability a little bit better. Also get the capability for you guys to raise hands so that when you've got a question. And unfortunately, we couldn't see you, but hopefully you got a kick out of seeing us. Be in Hanover.
Have a summer. Thanks so much. I'm sorry for those of you that had audio trouble, but hopefully you were able to get on. We'll see you for next